Before we start today's episode, I would like to quickly read you our podcast disclaimer. The content in this podcast is for general reference and educational purposes only. It is not meant to be complete or exhaustive or to be applicable to any specific individual's medical condition. No information provided in this podcast constitutes medical advice and is not an attempt to practice medicine or to provide specific medical advice, diagnosis, or treatment. This podcast does not create a physician-patient relationship and is not a substitute for professional medical advice, diagnosis, or treatment. Please do not rely on this podcast for emergency medical treatment. Remember that everyone is different, so make sure you consult your own healthcare professional before seeking any new treatment and before you alter, suspend, or initiate a new change in your routine. Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets,
two internal medicine doctors who spent years practicing traditional primary care. Over time, we realized something was missing from modern healthcare. A real understanding of how everyday lifestyle choices impact overall health.
We'll help you cut through the noise of the countless health influencers and their conflicting opinions. Because no matter who you follow, the basics of lifestyle medicine are at the heart of it all.
Welcome back to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets.
Hopefully you did well with last week's challenge. We had talked to Dr. Katie Donaldson about hypertension and talking about trying to reduce the sodium in our diet. And one of the best ways to do that is to eat more whole foods. So we wanted you to try to do at least one meal a day where you're making a meal just from whole foods and hopefully seeing how good that can taste. And you can find ways to do it that's not too time-consuming.
And today we want to wrap up all this talk about cardiovascular health. This topic is super important. That's why we've had 3 dedicated shows related to it, because heart disease is the leading cause of death worldwide, yet it's largely preventable. And this is something that we're very passionate about. So we wanted to spend some time here and give you the education you need.
So we had Dr. Cotter on 2 weeks ago talking about cardiovascular disease. He's a cardiologist at UK, and how to really try to estimate your risk for heart disease and how to really gain control over your heart health. And today we're going to go into a little bit more detail on some of these other numbers that your doctor may be looking at with you. Your cholesterol, as well as your metabolic health. I think this gets ignored a lot of times as far as looking at your risk of cardiovascular disease. But your metabolic health, your insulin sensitivity, how your blood glucose, blood sugar runs, all of these things affect each other and overall affect how your cardiovascular health is doing.
And we also want to touch on some of the more advanced testing you may hear about. I know there's lots of information out on social media about things that you should have tested, and we just want to give you an idea of when it may be reasonable to do some of that additional testing, or it may just be a waste of money and time. So we're going to get a little nerdy when it comes to that aspect today, but we just want to be able to educate you so you can feel empowered in making decisions.
So we've talked a lot about how broad heart disease is, and remember, heart disease can really be talking about a lot of different things. It can talk about your heart muscle, your heart pump, your heart valves, and whether or not your blood flow is going in the right direction. It can refer to your electrical system in your heart, meaning is your heart rhythm doing okay? But we're going to continue to talk today mostly about the blood vessels. You have 60,000 miles of blood vessels in your body. That's including all of your arteries, your capillaries, your veins, and that is pretty crazy to think about. If you lined up all of your blood vessels in your body, it could circle the earth 2.5 times, and that is all compressed down into your body. So this huge traffic system is very important because that is how every single cell in your body is getting oxygen and nutrients. And it's also how those cells are getting rid of the waste. So if you have an artery that's clogged, then the cells that are reliant on that artery can die. This is how a heart attack works. So if one of the arteries that is bringing blood flow to part of a muscle of your heart gets clogged, then that muscle does not get oxygen and nutrients. It can die, and that's a heart attack. Stroke is the same way. So a blood vessel that's carrying blood to your brain, if that becomes clogged, then that section of the brain that's supplied by that artery can also die, and that's a stroke. And we worry a lot about heart attack and stroke because they can have such a big effect on you. But we also have to think about the fact that all of the cells are receiving this blood flow and oxygen. So it's really important for your quality of life. So things like your muscles, your eyes, your skin, everything is reliant on this vascular system. So we want to keep it as healthy as possible. But how do you know if it's healthy? I think that's where it can be really hard.
And that is where your primary care doctor is trying to look at different things to assess and see what your cardiovascular system is doing. And so we really want to think about preventing many of these bad things from happening. And it's part of what many doctors are doing when you go for that annual physical, or should be doing, to make sure that we're reducing the risk of bad things happening in our actual vessels as much as possible, because they have such a big impact. And you can have such an impact personally on making a difference in your overall results. And it's always good information to have when you can feel empowered to be able to make a change into your health.
Yeah. And Sarah, can you tell our listeners what is the one blood test and picture we have to tell for sure how your cardiovascular system is doing?
I'm not sure there is just one. I think that's the problem. There's many different things that we have to think about. I know we talked about this with Dr. Cotter, and I kind of alluded to this, but I think so many times we think that, we should only worry about our cholesterol, and that's the only thing that matters when it comes to our cardiovascular health, but that's false. There's many different risk factors related to this, and that's what we wanted to dive into today and talk about each of the different buckets. I will say that we will not spend as much time on the first thing that usually happens when you go to your doctor, which is your blood pressure gets checked, because we did talk about this extensively with Dr. Donaldson last week. So if you missed out on that show and you're wanting to learn more about how blood pressure is impacted through lifestyle or the need of medicine to control it, please listen to that show when we go into all the details about that. Beyond that, we know that there are other things that are contributing to not only just your cholesterol, your blood pressure, but if you're having high alcohol consumption, are you smoking? And one that sometimes isn't talked about enough is your overall metabolic health. We want to give you some more information on how to understand how that is doing and some tests that we either do get on a regular basis or maybe is being missed. And it could be something that you want to explore a little bit more. We're not going to ignore cholesterol because it still does matter. It is a tool. So we'll jump in and we're going to talk about cholesterol. This could go on for hours. Cholesterol can be very complicated, actually. So we're going to just give an overview here, knowing that it is something that can be very personal because genetics plays a huge part into what's happening with our cholesterol. We do want you to understand, because I know this is just a common test that many people get, and once they get the numbers, they don't know what to do with them.
Yeah. And one thing to make sure that you understand also is we need cholesterol. All of our cells need cholesterol. It's a big component of the cell membrane that makes our cells function. So without cholesterol, we would not be able to survive. But because of that, our body is smart and it is able to make its own cholesterol. So most of the cells in our body make their own cholesterol, and our liver is an organ that makes a lot of cholesterol too for our body to use. So there's other things that need cholesterol too, including our hormone production, and then it's also a big component of our digestion. The problem is when we have too much cholesterol floating around, and when that happens, then the cholesterol can get into the wall of our arteries, and that can cause plaque formation and eventually blockage. When thinking about cholesterol, I'm going to simplify this quite a bit, but there's a couple reasons why your cholesterol might be too high. And it's either because your body is working too hard making cholesterol, so it's making too much cholesterol, or it's absorbing too much cholesterol from your gut, and that maybe it's just absorbing too much of the cholesterol that's there, or you're taking in so much cholesterol in your diet that it's giving it a lot to absorb. Or it could even be that it's just having a problem clearing the cholesterol from the bloodstream. So if we have a problem with any of those, then we're going to end up with higher blood cholesterol. This is where genetics plays a really big role. And you may have a problem with more than one of these things. It's also why we might see someone following a perfect diet with absolutely no saturated fat and still have high cholesterol. So just thinking about that, when you're getting your results from your doctor, you are not getting a result that is telling you, hey, you make too much cholesterol, or hey, you absorb too much cholesterol. You're going to get a result that's showing you total cholesterol, triglycerides, HDL, and LDL. That's usually what you're going to see on the result from your doctor. So what does that mean?
When you get your actual lipid panel or cholesterol levels, when they are tested by your doctor, they are broken down into different pieces. In the past, there was a huge focus mostly on total cholesterol. I know today, even when I have patients that are older, that is the number that they're always fixated on, is just the total cholesterol. But it's important to actually look at all the numbers that you're receiving in this test. Typically, on a basic lipid panel, you will get your total cholesterol. Many different references will say ideally you want that under 200, but really having it less than 150 is optimal. But that total cholesterol is actually combining multiple pieces of cholesterol together to get that number. So then we break it down and we're going to look at LDL cholesterol, which gets known as, and I put in quotation, as the bad cholesterol. And this is the one that we focus on a lot. It's the one that we have medicines to help reduce as well. So we pay a lot of attention to it. It's one piece of the puzzle to our cardiovascular health. It's not the only piece of the puzzle, though. Ideally, for primary prevention, so meaning you have not had a heart attack or stroke, or do not have other significant risk factors that are involved, we would want this number to be less than 100. You may have your physician giving you a goal of even less than that, but that could be because of your own personal risk. But in general, for most people, for primary prevention, if you haven't had anything happen yet, we're wanting that LDL number under 100 for a perfect score. And then HDL, which is known as I put in quotations, good cholesterol, is a number that we want to be higher. Ideally, we love to see that over 60. Now, men and women, they'll have a difference in their normal range. So they're slightly different between men and women, which you will see, quote, normal. But we would love to see both men and women above 60 if possible. And then the last piece that we typically see is your triglycerides. And that is something that is an actual indicator more of your metabolic health in general, and something that we typically don't talk a whole lot about with cardiovascular health, but it is a good number to pay attention to, because if you are having numbers higher than 150, then we are having more concerns of metabolic syndrome that might be occurring. So ideally, we like to see that number under 150 when we're testing for that. But we typically use medicines to treat it at a much higher number than that 150. So you may have a triglyceride of 200-300, not really receiving medicine for it, but that doesn't mean it doesn't matter. It still is telling us that something metabolically is going on and we need to be making changes in our lifestyle and our overall health in order to reduce that number in general. So those are the big four players that many times that if you've had your lipid profile, you at least got these numbers for reference.
Yeah, and we'll talk about metabolic health a little bit more in a few minutes with triglycerides, because that's really, if you're eating an excess of calories, that's when you're going to see those triglyceride levels go up. But the triglyceride levels changing, even though we don't focus on them as much, when they change, they can affect the other numbers too. So we'll come back to that. And the HDL, I just wanted to clarify, if you have been wondering, why do we call that one the good cholesterol? It's because it really acts as a cleanup crew. So if the amount of cholesterol in the cell gets too high, either because it's making too much or we have too much coming in, then that can ultimately cause the cell to kind of crystallize and die. This is where HDL can really be helpful, because it tries to clear that excess cholesterol from the cells to maintain the cell's health. So it offloads that cholesterol and tries to transport it away. and either just goes ahead and transports it back to the liver, or more often, it takes that extra cholesterol and gives it to an LDL, and then the LDL recirculates it back to the liver. So the HDL is good in that it is clearing this excess cholesterol from the cell and helping it preserve its function, but it also works with the LDL to do that clearance. So all of the particles are working together. So we kind of categorize the HDL as the good guy because it is coming around and clearing this excess cholesterol, but it also depends on the LDL to get rid of some of that cholesterol it's picking up so that it can keep going around and gathering more from the cells that need its help. So all of it works together. So really encourage you to not just think of it as HDL is the good cholesterol and LDL is the bad cholesterol, but that we want the whole system doing well and working together. And that's kind of why we use the ASCVD risk calculator. And we talked about this with Dr. Cotter. We've moved away from looking at just specific number values to using all of them together to estimate what is your chance of having a heart attack or stroke in the next 10 years.
Because when we use these risk calculators, we can actually see the result of reducing different numbers. So those risk calculators, as we talked about before, it's going to be looking not only at your cholesterol numbers, but your blood pressure, whether or not you have diabetes, whether or not you smoke, your age, your sex. All those different aspects are going to play into that. So in general, when you're trying to make a decision of whether or not you need to treat your LDL, the, quote, bad cholesterol, and bring that number down, it's actually the whole picture that's supposed to help make that decision. Because in general, when you are taking a medicine to reduce that LDL, it's only one tool in the toolbox. So if you have slightly elevated blood pressure, you have slightly elevated LDL, you may have just been diagnosed with diabetes but have a controlled A1C, it's still important that you're not only just taking a statin to reduce your LDL to goal, but you're also managing all these other risk factors because it takes the whole bucket in order to have a substantial difference in your overall risk. If you only focus on one piece of it, it's actually pretty small.
Yeah, and I'll put the link to that ASCVD risk calculator, and I would encourage you, get on there and plug your numbers in and then play with them. See, what happens if you take your blood pressure down 20 points? How much does that improve your risk? How much does it improve your risk if you can reduce your LDL by 20 points? See what happens there. See what happens if, let's say you don't have diabetes right now, but that's possibly something in your future. Click that button to yes and see what happens to your risk. Really take the time to experiment with that and see what happens. You can also look and see, let's say my numbers stay the same, but my age goes up by 20 years. See what that does to change your risk as well. So it's really about looking at you as a whole instead of one specific number. And then there's a lot of new tests that I guess they're not really new. I think they're new in the light of social media and kind of have had a lot of buzz lately. So we wanted to talk a little bit about what those tests are, what they mean, and could it be helpful to you or not?
Many of these tests are looked at as risk-enhancing features, and a lot of times are used if you're in more of a gray area to decide, hey, do I need to be more aggressive and start medicine? Some of these tests may be helpful if they're elevated as well to show you maybe I don't want to just do lifestyle and I want to do both options of medicine and lifestyle. So it's not going to be a black or white answer that you're going to get from us here today. I'm just going to put that out there.
Actually, I think the more I learn about cholesterol, the more gray it seems to me.
It's much more gray the more you dig into it. Two that are related to your overall cholesterol are ApoB and lipoprotein little a. You probably have heard these if you do follow anyone in social media in the health sector. These get brought up, and they can be used to help see if you have higher risk in general. If you have an elevated ApoB, which does tend to correlate a lot of times with your LDL. So many times it's not checked because a lot of times if LDL's up, so is ApoB. sometimes they don't correlate perfectly, and that could be a reason to be more aggressive with treatment, or, if you're on the fence, and that's also extremely high or higher than necessarily your LDL, a reason to maybe start medication. That is how that lab is used, but many times insurance doesn't cover it. So a lot of times your primary care physician or even your cardiologist isn't checking it because they're using the lab test that is affordable to them and their patients, or I should say affordable to their patients, knowing that many times if you come back and you have a really high LDL, it's not going to change their management what your ApoB is, because they're still going to recommend medicine. It's really used more in that gray area of making those decisions.
Yeah, and so the ApoB is just a little protein that's like on the outside of your LDL particle, but it's also on the outside of several other particles that may not show up on your lipid panel. So there's a VLDL, and that shows up on some panels. You might have that on yours. There's also an IDL, and these have to do with different sizes of lipid proteins. So the ApoB gives you an idea of how much do you have of all of that stuff instead of just the LDL. So some people would argue, does it really make a difference? If your LDL is high, you probably have high, all of it. So does it change your management? There are some people that can have a relatively normal LDL, but still have an ApoB that's elevated because they have more of these other particles. But that is pretty rare. So if you're someone that's on the fence and you're, wanting to know more to decide, do I want to do treatment or not? Then maybe it's helpful. Otherwise, it's probably not telling you much more than the LDL.
And then our other test is the lipoprotein a. Previously, we never really tested for this. It has become more common to test for. We feel like this one has more of a genetic component, as well as something to consider testing, especially in patients who had that family history of early heart attacks, considering to see if this is elevated. And there are many studies going on currently looking for medicines to target this specifically and reducing its level. But because we don't have a medicine to actually target it yet, that is a reason many times it's not checked, because there's nothing we can necessarily do to fix it.
Yeah, so you either make lipoprotein a or you don't, and that's the genetic reason. So if you were to check it, it's something you only need to do once, because you make it or you don't. If you make it, you're going to continue to make it. If you don't, you shouldn't start making it at some point. So if you are going to check that, that's a one-time test, and the reason that we care about it is because it's another protein on the LDL that seems to make it more atherogenic, and what we mean by that is makes it a particle that's more likely to cause plaque and cause inflammation in your artery. So it kind of makes your LDL a little more potent.
And so, again, that is a test that if you have a strong family history, your LDL's kind of in the questionable area, and you're wanting to figure out how aggressive do you need to be in managing all of your risk factors, right? All of them. That's how you would use that information of knowing, hey, I just genetically have this higher risk, so I want to be sure the things I do have control of, I'm being very aggressive with. That's how you would use this test in life.
And probably in the next 10 years, we will have some medicines that target lipoprotein a specifically. So when those do come out, then it might become more widely available, or might be more covered by insurance to get that checked, because then we actually would have a specific treatment for it. Another one that a lot of people are looking into is high sensitivity CRP. And this is looking at inflammation. So again, you can have LDL that can get into the wall of your arteries and really not cause an issue. Your body kind of takes care of it over time. It becomes part of the wall, and no big issues have happened. It's problematic when it causes a lot of inflammation, and then the body's trying to fight off this LDL that got into the wall of the artery, and that's when we get these plaques that cause problems. So the thought behind the high sensitivity CRP is, do we see that level of inflammation in you? Because if we are seeing a lot of that, you're more likely to be getting these plaques that could be problematic.
And when it comes to improving this lab, It's very tricky because it depends on other conditions that you have. If you have, for instance, an autoimmune condition and you have elevated inflammation in general, really we need to be targeting and managing your autoimmune condition better. There's also many things in our lifestyle that can increase inflammation. And so when that number is elevated, if there are some areas for improvement in your diet, that is something that you can try improving your diet, improving exercise, improving stress management, and see if you can reduce some of that inflammation in your body through lifestyle change. But again, we don't have a targeted medicine for that lab.
So if you were arguing for or against getting that done, if you saw that it was high, it might be more motivating for you to really try to adopt a lower inflammatory lifestyle, really focusing on whole foods and foods that lead to lower inflammation, reducing your stress, because stress hormones can also cause a rise in these things. On the flip side, you could argue, just do those things. What's the point in checking it and letting it freak you out? You should just do these healthy things anyways and try to kind of have this lower inflammatory state to begin with. So that's kind of how you can argue for or against that. The last one that I feel like I'm seeing more and more stuff about is particle size. And we'll get to this a little bit when we talk more about metabolic health, because I think that's really where we see the change in particle size. When your metabolic health is poor, we're going to see smaller LDL particles. Sometimes your HDL particles may be bigger and then get smaller. And all of this has to do with the transfer of cholesterol and triglycerides in and out of these cholesterol particles. And there are certain combinations of sizes that you see that might reflect that you have poor metabolic health. So that can be helpful in diagnosing that. If you were going to argue against that, as far as argue against the need for looking at that, there are other ways to look at metabolic health. And so also, if you're doing lifestyle change to improve your metabolic health, then does looking at the particle size really change anything for you? So it's one of those things, like if you're going to go all in and you're going to do all the things to try to improve your metabolic health, improve your inflammation, improve your cholesterol, is it worth looking at all of this? If it motivates you to look at that, or if it motivates you to have something to compare to over time, or if it's going to be a way for you to decide, am I going to just do lifestyle, or am I going to do lifestyle and medication, then that's where it really plays a role.
Other times that the particle size, it can even be a situation that helps some people decide on an additional medicine as well to get even better control if they are in that high risk category. So definitely not something that insurance typically covers. It's not something that most physicians are routinely checking. Really, all four of these labs we just wanted to talk about so you have an understanding of what they are, when they may be helpful, why they may not be helpful, and why right now routinely they're not necessarily checked.
And you could argue that checking ApoB would actually be more helpful than checking LDL. But the problem is things are slow to change. So changing labs, changing insurance coverage for labs, all of that is very slow to change. And so one day we may see ApoB as part of the regular lipid panel. I wouldn't be surprised if that happened at some point. But there's a big cost in changing how we look at things. And then one more caveat on whether this is worth it for you. If you think to yourself, I am not going to do anything different, and I think Dr. Cotter said this too, if you know, I'm not going to change how I eat, I am not going to change whether or not I take medicine, then it's really not worth it to pay to do these additional labs. Think about it as, is this going to change what I do? So thinking about changing what you do, we wanted to get into a little bit about how much does diet play a role in your cholesterol. This is one of those times where I have to admit that lifestyle has some limitations, because I wish that diet played a bigger role in this than it does. When you look at the cholesterol that's in the lumen of your intestines, so meaning just inside that tube of your intestines that is ready to either be absorbed or not, the majority of that cholesterol, 80%, is actually cholesterol that your body made and was secreted out as bile acids from your gallbladder. So the majority of cholesterol that's sitting there deciding whether or not it's going to be absorbed is actually cholesterol from you. And the smaller portion is cholesterol from what you ate. Now, you can overwhelm that. If you're going to eat a whole bunch of high-fat food, then you're going to have more cholesterol in there to be absorbed. But there's only so much that changing what's coming into your mouth is actually going to change how much cholesterol is there in your intestines to be absorbed. So one thing that can potentially change how much cholesterol is there to be absorbed is fiber.
Fiber is so helpful, specifically soluble fiber, because it inside your lumen is going to bind up some of that cholesterol and also is going to impact the good bacteria, and it's going to make it into a substance that's not going to get absorbed and then will be kind of moved down and go out in your stool. And that's going to make a difference in your overall cholesterol absorption. So sometimes we don't spend enough time talking about fiber and its importance in heart health, even though we see those little labels at times on many different food products, but it's often forgot when we're talking about ways to improve our cholesterol. So soluble fiber in our diet is very important.
Yeah, and I've seen a lot of patients try like Metamucil and fiber supplements over the years. Sometimes I would see some benefit from that. I think where you're going to get a better bang for your buck is really trying to increase the fiber in your diet, especially because that's going to be the way to promote those good bacteria that are helping convert the cholesterol into that form that's not going to be absorbed. So back to that thing I love, 30 plants a week. The more variety you get, the more you're going to fuel that good bacteria that's going to help you. But here's where, things can be different for different people. So if you are someone that is absorbing too much cholesterol from your gut, then changing the fiber, because that's getting rid of some of it, you still have a lot there. Changing the fiber might help you, it might not. It's probably going to help you to some degree, but you may see a little bit of change in your blood work, or you could see a big change in your blood work. And this is where I think it's really important to be an investigator with yourself. And if you want to try really increasing your plants and seeing how that works on your cholesterol, really dive into it and then recheck it and see, did that help me? Did that not help me? And kind of just investigate for yourself how much of a difference that makes.
Next, we'll talk about saturated fat. We used to previously, decades ago, only talk about cholesterol in our diet, but saturated fat has impact on our lipid panel, specifically our LDL, in the fact that saturated fat in our diet decreases LDL receptors that are available to clear it from the bloodstream. So if you increase your saturated fat, then there are going to be less receptors on there to be able to remove it. And so this, again, is going to have some genetic component. So some people can be very aggressive in reducing their saturated fat, knock it out of the park, and their LDL doesn't budge as much. That doesn't mean that they did something wrong. It just means that they're not going to get that same response as someone else. This is something we see a lot of times when people are on a keto diet that is a very high-fat diet, and your overall lipid panel could look beautiful by making that change, but other patients may have way worse lipid panels after doing a keto diet. So it's, again, just as Kitty just mentioned, I really think testing your response to dietary changes by rechecking your lipid panel is very important so you understand if you're making an impact on that specifically or not. Now, when you're making dietary changes, in general, it can be helping other parts of your overall health, so it's still worth it. But where you're spending your time and energy, if you're only focused on your LDL and that's the only thing you're trying to fix, we want you to actually get some bang for your buck. So when you make these changes, doing a recheck is going to be helpful to understanding yourself and what change might occur.
You hear a lot about fat because we went through our low-fat phase in the 90s, and then we found out, that really didn't reduce cardiovascular disease. And so now we're in this phase of it's fine to eat fat, but it's really the saturated fat that we're seeing that can have an effect on these LDL receptors and therefore keep your LDL level higher. So the polyunsaturated and the monounsaturated fats do not seem to have the same effect on the clearance of LDL from your bloodstream. So you don't need to worry as much about those. And it seems like cholesterol, not as much either. Having said that, again, I've had many patients that have started eating eggs every day. And some of those patients, cholesterol stayed totally the same. And some, their LDL jumped up 30 points. So really it's coming down to, are you overabsorbing? Are you overproducing cholesterol from your liver? And that's going to affect how you respond to different diet changes. So make a change and check yourself. We don't want you to get discouraged by thinking that your diet's only going to have a certain amount of effect on your cholesterol. There are lots of other options to help with reducing that LDL in the form of medications. The most common one that you hear about is statins. So I think statins get a bad name a lot of times. A lot of people feel like they have side effects related to statins, including muscle pain. Some people feel like they have some brain fog related to statins. Then there's also a small amount of people that can have a little bit worsening of insulin resistance when taking statins. But we know that statins do reduce the risk of cardiovascular events, especially in people that are higher risk. So when your doctor is trying to decide if you should take a statin, they're really looking at, not just looking at that one LDL number anymore. They're looking at that ASCVD risk calculator, taking everything into consideration, and then deciding, is your risk high enough that you should take a statin to try to bring that down? So if you're someone that's already had a heart attack or stroke, then we're talking about something called secondary prevention, meaning we don't want you to have a second event of one of those things. And that's where we see statins kind of have a bigger impact. It seems to really reduce the chance of you having a second event more when your risk is higher. And we know if you've already had an event, your risk is pretty high that you could have another one. So that's where statins can really probably make the biggest impact. And if you have had a heart attack or stroke, and you were seen by a doctor, I can guarantee you they talked to you about being on a statin and probably had you on one before you ever left the hospital.
Now, to contrast that, when we talk about using them as primary prevention, they're really only one tool in our toolbox. We've talked about this because, again, the statin is focusing on reducing that LDL number, but that is only one of our risk factors that could be impacting us. So it's really important. Again, you can play with a risk calculator and seeing what does an actual reduction in my LDL do to my overall risk versus if I spend more time reducing my blood pressure or making sure I don't get diabetes. Where is my biggest impact on prevention? Because not everyone is going to not have a heart attack because they started taking a statin. It is not like an antibiotic where it cures your bacterial infection. It is just there as a tool to, again, help reduce your risk. So our whole goal is to look at the whole picture and do everything we can do to reduce our risk in general. And so that's why we wanted to take time to talk about each of these buckets and not focus just on this one, because it is not a one pill fixes all heart disease. It doesn't work that way.
And I think the reason it's gotten a lot of attention over the years is, it was one of the first things we had to actually make an impact on LDL that was able to be tolerated well by the system. There were some other drugs that came out first, but they were difficult to take. And the thought is that if we get our LDL down really, really low, that then we will not get plaque in our arteries. I mean, it has to be really low. But that's the thought, is if you can get the LDL low enough that you won't be building up plaque in the arteries. The problem is that the statins don't always get everyone there. And so it may help you to some degree, but it may not be getting your LDL low enough to where you're at that point where it's not going to cause you an issue. We do have some newer medicines that have come out. The PCSK9 inhibitors are the newest kids on the block, and they can get the LDL down even lower. Right now, they're only approved for certain high-risk individuals, but it's going to be interesting to see if we can really get the LDL down with these newer medicines. How much is that going to help in the long run?
And that's where we will have to wait and see what our evidence, how it changes with more opportunity to use different medicines. But in general, our whole purpose here today is we want you to have these discussions with your doctors when you're making the decision about medicine, so you understand, is this medicine actually making an impact in my overall risk? And when should I consider it if it's not now? Just so you actually can feel like you are empowered in your decision making. Because so many times, and I've heard this from many patients, they feel like they're just, prescribed something without the information of why. And so that's why we want you to understand why we use this medicine, what's it actually doing, but it is not a cure-all.
Yeah. And so the other thing that we've already touched on but want to go into more detail is the impact of your metabolic health and how all of this is connected. Insulin resistance is something that is becoming more and more common in our population. We're seeing a lot of people in that pre-diabetes range where they're starting to have some insulin resistance, but not all the way to diabetes. But even at that point, we are starting to see the changes from it in our cholesterol and in our cardiovascular health. So if you are eating more calories than you need, that's usually going to be put into the form of triglycerides to be used later as a source of energy. And so the problem when you get too many triglycerides is that it affects both your HDL and your LDL. So it essentially makes your HDL less stable, and they don't survive as long, and they're not able to recycle themselves as easily to be continuing to help clear your cholesterol. So it ultimately, you can think of it as decreasing your HDL and decreasing the function of your HDL. And then it also impedes the clearance of your LDL particles. So it affects those LDL receptors we were talking about that help pull the LDL from the circulation. And it also affects the size of the LDL particle, and it makes it harder for that smaller LDL particle to be cleared. So there's fewer receptors to clear it, and now the particle is a shape that makes it more difficult to clear. If you think about it, you're eating too much, got too many calories, the triglycerides have kind of messed up these other molecules, and now we've got not enough HDL to help us clear, and our LDL is circulating for longer, all of which are going to cause a big mess.
Now, the good thing about triglycerides, for many people, you have more control over. There are some people who have very high triglycerides, 500 and above, that do not have as much control based off of their lifestyle. But for many people, you can make lifestyle changes to bring that down. We know that decreasing carbohydrates and refined grains can help reduce your triglycerides, as well as reduction in alcohol. High alcohol consumption really can drive up your triglycerides and have a negative impact on your overall metabolic health. And both of those you can see a substantial change just even within months of making those lifestyle changes.
Yeah, another one that can help is exercise. Oh, I love it when we get to mention exercise. But exercise is going to help improve your insulin sensitivity. It's going to help you use up some of these triglycerides for energy. And so exercise has a lot of different effects to affect your cardiovascular system because it's affecting it on this insulin resistance, insulin sensitivity, which is also going to affect your actual cholesterol values. And then it has some just straight effects on the vasculature itself, causing some better dilation and overall also improving blood pressure over time.
Another test that is commonly obtained, I should say 2 tests. A lot of times your primary care doctor will get what's called a fasting glucose, and that is typically used as a screening tool for prediabetes or type 2 diabetes, as well as an A1C, which can be used as a screening tool as well. They are slightly different, though. When we talk about a fasting glucose, that is telling you what your blood glucose is or blood sugar at that exact point in time. Now, we use different ranges to tell whether or not you're at risk for diabetes. So prediabetes would be a level of 100 up to 126. And if you have more than one blood glucose above 126, as well as one-time reading that's elevated with symptoms, you can be diagnosed with diabetes with that specific test. You know, not every physician is doing both an A1C and fasting glucose, but that is a test that I do consider that you pay attention to if you've had it on your lab work and look and see what your number is. Because prediabetes has become so common, many times it's not even being paid attention to when we reach that level of prediabetes. But I will tell you, it is important to pay attention if you have reached that level because you're going to be able to have the biggest impact on your insulin resistance and actually improving that sensitivity at this lower level with your lifestyle changes. So the opposite test, A1C, we use that as well to screen, but it's slightly different where the fasting glucose was one point in time. The A1C is a number that's giving us an overall average of what your blood glucose may be running over 3 months. So it actually is impacted significantly more about your activities over every single day versus that one-time reading could be impacted over the last week. The numbers that we use for diagnosis there is a 5.7 up to 6.4 is pre-diabetes, and then 6.5 and above falls in the type 2 diabetes range for an A1C. If you have seen that test as well ordered by your primary care physician, that's its purpose, and it's giving you a great overview of what's going on with your blood glucose or blood sugar level over time. I personally like the A1C better than that fasting glucose just because it's more data. So it really helps me a little bit more to see what's going on in someone's overall lifestyle better than the fasting glucose alone.
I think it's helpful for everyone to have that. Unfortunately, insurance doesn't cover it for everyone. You have to have a reason. For most plans, you have to have a reason to check it. So if you have had a fasting glucose over the normal value, or even just a random glucose over a certain point, then it should be covered for you to check an A1C, which will give you a better idea about that. Something else you might see people talking about checking is a fasting insulin. And that is also another great tool to kind of tell where you are on that insulin resistance scale. But again, it's one of those that insurance isn't necessarily going to cover. So figuring out what your insurance is going to cover, how much do you want to look into it in more detail to see where you are, and is that going to change what you're going to do? That's kind of the way to think about it.
And the fasting insulin is used many times to actually pick up if you're headed in the wrong direction. You can have a normal A1C that has not hit that prediabetes range, but you can have an elevated insulin level. So we know that that's putting you at a higher risk of heading towards prediabetes. So if you have already have an A1C that is in the diabetes range, that test is not as useful.
So again, this is something where you can have more control. We've kind of already mentioned our frustrations with whether or not diet's going to make a huge impact or a small impact on your cholesterol levels. This is somewhere where you can see a bigger impact. And if this is something that you guys are really interested in, let us know. We could do a whole episode talking about insulin resistance, but really working to try to decrease your refined carbohydrates is how you will want to bring this down. And if you do it and you start really working on a whole food diet, you can really see an improvement in this pretty quickly.
And another reason to eat more fiber.
Yes.
Because it also makes a difference as well. In general, I know we don't want you to walk away feeling like you don't have an actual impact. You do have an impact. This is just sometimes not talked about enough for your cardiovascular health. So remember, your overall metabolic health is impacting your cardiovascular health.
Yeah. And again, we really do want you guys to check out this ASCVD risk calculator, looking at your risk of heart attack or stroke in the next 10 years. And there is a button on there to click if you have diabetes or not. So even if you don't have diabetes, but your A1C is getting close to that prediabetes range, or you're in that prediabetes range, really look and see what happens to your risk when we click it over to yes. And that might be a big motivator for you to make some changes to help bring that blood sugar down and improve your insulin sensitivity. There's a lot of risk factors that go into this calculation, and even though you don't have control over all of them, you do have an ability to improve any of them. Some of these you have less control over, but it's also looking at your blood pressure, your cholesterol, your HDL, whether or not you smoke, diabetes, and weight. And so you may need medicines to help control some of these, or you might be able to help control some of them with lifestyle. But the more you can get those risk factors down, the bigger effect that's going to have on you over time.
Speaking of that, we did talk about tobacco use with Dr. Cotter, but just to bring that up again, it makes a huge impact instantly if you stop smoking. It's not something that you have to build up over years of not smoking to see the changes occur. So if you really want to get the biggest bang for your buck on what risk factors should I focus my time and energy on, if you currently smoke, that is where you need to spend your time and energy first, because it is going to improve your overall health and decrease your risk dramatically.
Really quickly. And there are a lot of other things that are going to affect your risk One of which leads us into our topic for next month, and that is menopause. So menopause can increase your LDL and cause other changes in your cardiovascular risk, primarily because that drop in estrogen is going to lower the LDL receptors, just like saturated fat did, so that you end up having a higher circulating volume of LDL cholesterol. There are so many things that impact this, and what we really want you to take away from today is there's no one number that makes just the difference. There's no one thing that's the right thing to do. So you want to look at yourself as looking at all of these risk factors. What can you do for each of them? And then really just make a change and follow up to see how much you responded to each thing that you try. And that's going to keep you motivated to keep going.
When we think about lifestyle changes and the different pillars that we talk about, the great thing is many of these changes help all the things. So
yes.
It is helpful. Sometimes it gets a little nuanced, if you're focusing more specifically on saturated fat, or you're focusing more trying to just hit your fiber goal. But if you're kind of taking the step back and doing the big picture and just working on improving your overall nutrition, improving your movement, and improving your stress management, it's actually going to help each of these risk factors. So you'll improve your metabolic health and your actual decrease your diabetes risk. It can improve your cholesterol. It can improve your blood pressure, all the things. So I think sometimes we really want to just make everything definitive and, find that one thing to only think about. But if we just spend time making those small steps and try to reach an overall healthier lifestyle, we're going to reduce our risk.
Even things like controlling your stress, getting good sleep, all of those things are going to benefit your cardiovascular risk. Don't get too focused on just one thing and only focus on that. Okay, I hope that you've enjoyed this and not been too bored.
I know we were afraid that this show might be a little bit too much information, but because of that, we have set up this next week's challenge to be, if you have not had an annual exam with your primary care provider in the past year, please schedule it now.
Because it might be 6 months out.
Yes, because it's important that you're having these discussions, that you're making sure that you've had the appropriate screenings. And if you've had them, ask these questions that we talked about today so you understand your risk and you feel empowered to make the decisions, as well as know, hey, I'm doing a good job. This is making a difference. Or, hey, I need to step it up another step.
Again, your challenge is to set up that physical exam and really think about what it is you want to get out of that visit with your doctor and write those questions down. And we're so excited to switch focus next week and really dive into women's health in the month of March.
We have some really great topics talking about menopause, PCOS, pelvic floor. You should be excited to hear these speakers because they are going to be great.
So we hope you have a great week, and we'll be back next time with Dr. Deidre Bashir.
Bye.